I think we should be live right now, right? Yes. Good morning, everyone. Thank you so much for attending our session today. We are honored to have Dr. Mittal, a family physician, here with us. As always, please remember that the Google form will be posted at the end of the live stream. With that being said, Dr. Mittal, you may start sharing your screen whenever you'd like.
All right, let's see, 1 second here, entire screen. Hi, everyone. Hope you're doing well. My name is Anupam Mittal, one of the family physicians that is working with WebShadowers. Thank you guys for having me and welcome everyone to the live stream. So let's go ahead and start. So again, family medicine. I want to talk a little bit about what family medicine is, what the path is to how I got here, a little bit about me, and we're going to do a couple of cases as well. So about me first, I am from California. I did my college out here at University of California, Irvine. From there, I started medical school right after college at Turo, California School of Osteopathic Medicine. That was up in Northern California, and of med school. Did residency out in Baylor Scott & White in Round Rock, Texas, near Austin. And currently I work at Kaiser Permanente in Southern California. So just a little bit about me. Disclosures, these couple of cases that I'm going to be talking about are examples only. There's no actual patient information used here. My role in this talk is purely educational, does not reflect the positions of my med school, my residency, or my current hospital of employment. This is how I think about cases and how I approach family medicine. It doesn't necessarily reflect the standard of practice or different board specialty recommendations. So objectives. I want to keep this casual, a very casual person. That's how I approach teaching and medicine in general. And I want to keep this as close to disclosures here. My role in this talk is purely, I don't want to give you guys a lecture on pathophysiology, current hospital, how to practice medicine. You're not quite there yet. So I want to keep it as so, you were that shadowing me at work. So with that in mind, there's a few things we want to talk about. So one, what is family? So objectives. I want to keep this in a couple of different scenarios. So just the basics of chest pain pathophysiology. What I'm going to describe to you is what I would describe to you again if you were in person at your current level of knowledge or approximately your current level of knowledge and the level of knowledge that my patient would have. So it's pretty much the same explanation I would give my patient as well. So it's going to be brief. But I think for your level of pre-med, it's appropriate. What is a differential diagnosis? That's a term that you're going to hear a lot as you move down the path, and I'm sure you've heard in some of your other talks as well. So we'll talk about that. What are some of the differentials for chest pain? How to assess and treat chest pain in various scenarios like we're talking about. And the big one, I think, more than anything, is how to communicate with patients, and I'll get into that. What is a differential medicine? The kind of quote you hear a lot is "jack of all traits, master." Yes and no. I think that's a quite an oversimplification. So let's talk about the path a little bit first. After college, at some point, whatever you end up doing afterwards, once you get into med school, it's 4 years of med school and then 3 years of residency. Fellowships available, all of them, but you can do sports medicine, geriatrics, obstetrics, ultrasound, community medicine, palliative care, lifestyle medicine, urgent care, integrative medicine, administration, sleep medicine, reproductive health. I mean, as you can tell, you can literally do anything from family medicine. You may not do sleep medicine to the same level that a pulmonologist does, and so that's where this term "jack of all trades, master of none" came into place. But people go into a lot of areas that you wouldn't expect after even not doing a fellowship. For example, cosmetology. People end up making like med spas and just doing Botox, fillers, cosmetic stuff like that, and from family medicine, and that's quite common. Where can you work as a physician? You can work in the clinic, you can work in the hospital, you can work in the urgent care, you can work in nursing homes, you can work in ER, you can work in private practice, you can work for the government and the VA system in the ER, you can work in so many different places. It's really a versatile specialty to go into, and there's really anything you want to do, you can do, which is great. Residencies for family medicine, it's a mix. I think generally residencies tend to focus for family medicine more on the outpatient side. So you're always going to have to do some level of inpatient. By inpatient, I mean working in the hospital, but generally, it is more outpatient based. There are some um, residencies that are more inpatient focused, and that's fine. That's totally fine. Most people that's family medicine tend to work solely in the outpatient or the clinic setting, um, and areas that you get trained in when you're going through your training in family medicine. You go through obviously family medicine itself, critical care, orthopedic surgery, hospital or inpatient medicine, GI, cardiology, endocrine, nephrology, OBGYN, pediatrics, ID or infectious disease, ophthalmology, ENT, geriatrics, urgent care. I mean, it's literally everything. And that's what's kind of cool. And this last line where it says, honestly, everyone does the same stuff. You know, people go into this path of family medicine or any specialties thinking, I have an idea of what this is going to be, and this is why I want to do that specialty or why I don't want to do that specialty. For example, someone says, oh, I want to become a general surgeon or an orthopedic surgeon because I don't want to deal with people's chronic conditions and managing their diabetes and their hypertension. And that's totally fine. I get that. But you'll find the more you go through it and you experience different specialties that you find everyone does the same thing. So if someone comes into my office and I'm an orthopedic surgeon and they need a hip replacement, but their BMI is, more obese, they have uncontrolled diabetes, I can't do that surgery. That surgery is going to fail. Their recovery is going to fail. And so what am I doing as the orthopedic surgery provider? I'm counseling them on their diabetes. I'm counseling them on weight loss. I'm talking about diet, nutrition, and exercise with them. So, these lines are honestly very, very blurred. And it's a little bit of a misnomer. And it's not just with family medicine, it's with all specialties as well. So, people I always tell people when you go in down this path of med school, don't say, I want to do this and that's the only thing I want to do. Keep an open mind, because you may find the more you experience these specialties, again, the lines are blurred and it's not what you thought it was, and you may change your mind, and that's totally fine. So that was just a little bit about the path of family medicine. What's to get out of this lecture? Kind of similar to what I said in the objectives. How do physicians think about a case? Don't focus on the chest pain itself that I talk about. It's going to be, how do we think about assessing a case, a patient as they come in, and how to talk to patients. I didn't put as many lines and slides about how to talk to patients. It's going to be more the questions you ask and whatnot. So I love this quote. Brownie points if you can tell me where this post came from without looking it up. To be able to bear the burden of people's lives without breaking, it's the greatest gift we can be given. That's about family medicine in general. So I just always liked it. It really speaks a lot to the resilience of physicians in general, and the value you get out of this job, which is a lot and pretty cool. Any questions so far? I'm gonna have another device set up to ask questions. Do you guys have anything? I'm gonna have a few slides throughout asking questions so I can kind of break it up. Hopefully I'll get to answer a number of your questions. How did DO school prepare you for your career? Prepared me very well. I think people talk about between DO and MD, and I know that's been answered in some points by other videos. And obviously there's the OMM, the osteopathic manipulation, people's aspect of DO that we do. And Frank, 90, 95, people talk about the difference between DO and I know that's obviously there's the OMM, the osteopathic manipulation that we do. And to be frank, 90 OMM. And the talk used to be this whole host had and MDs didn't. And the DO thing wasn't as accepted or wasn't as, whatever. That may have been true. But to be honest, I have a lot of friends and family members who are MDs, and I don't see that path was any different. I do think in general that DO schools are a little bit less focused on research in your first 2 years of med school. So there's a lot more emphasis on how to write notes and how to talk to patients and, some of that. So I think it prepared me very well. Why DO over MD? Again, to be perfectly honest, that's where I got in. So that's where I went. Work-life balance. Well, it's harder in residency for sure. When you have upwards of those 80-hour work weeks, it's tough. It's tough. Right now, as a attending, it's 40 hours a week, so it's significantly easier. So it's not bad. And at some point at this path, you're not going to have a work-life balance. You're going to be working a lot more than playing or relaxing, and that's just the nature of it. But you'll get through it, and it does get better. Let's see. What other activities did you do as a pre-med apart from classes? So classes, I did one to two. One that was my main one, but two volunteer like pre-med clubs that I was a part of, and really just stuck with that for a number of years and went through. I did bench research for a really brief amount of time, a couple of quarters, and that was awful. So I switched to clinical research, doing ultrasound, clinical ultrasound in the ICU and ER, which was really cool as well. What made me choose family medicine? ER first, and found that the personalities in the specialty weren't for me, and I didn't want to work nights for the rest of my life. So I figured I could get a lot of that kind of work, that more urgent care and high acuity work through working in an urgent care, and still have the lifestyle with the hours and whatnot. What would you recommend to someone who's planning on waiting until going to med school until they're late 20 due to financial reasons? That's totally fine. I mean, I remember in my med school class, there were people over 30. There was one lady in her 40s with like 4 kids. So you can go back whenever you want. So waiting until it's the right time for you and you have a financial plan in place is fine. Totally fine. Are there DOs and specialties? Yeah, some of the specialties that I mentioned before as well. So let's move ahead. Let's talk about chest pain now. What does that mean, and what is the pathophysiology? In a way, it depends on the situation you're in, and that'll be the two cases we talk about in the chest pain in the clinic setting and chest pain in the ER. You have to think about the anatomy, and not just of the heart, but surrounding structures. In your chest, you have your ribs, you have the fascia, the muscle, the tissue, you have the lungs, you have the blood vessels, aorta, veins, and you have the heart. So there's all these different things that can be involved that can potentially cause problems. So you have to be aware of all of that when you're assessing someone. In addition to their comorbidity. So what did they have beforehand? Is it their diabetes, if there's the hypertension, et cetera? Think about non-anatomical issues, things you can't necessarily quantify, the stress that someone's going in, in their life. Is someone coming in with chest pain and, a week ago their spouse just died, and they're trying to organize the funeral and whatnot. So that's not things you can really quantify, but it's something you definitely need to take into account when you do that. So we'll talk a little bit more about that as we move into each case. Differential diagnosis. So what does that mean? Differential diagnosis is different diagnoses that may explain the patient's symptoms. For example, if a patient comes in with cough, what am I thinking as a potential cause for that? Do they have pneumonia? Do they have COVID? Something very relevant right now. Is it allergies? Is it a simple viral infection, et cetera? So what is my potential source of diagnoses that could explain these symptoms? And why is it important? You can't ask the right questions, and you can't rule out a disease process unless you think of it first. So you have to know your stuff, right? That's why you go through your training. That's why you read. That's why you go through all these tests. Through this process, is you need to have the knowledge base. You need to be able to think of all these differential diagnoses, because if I don't even think about heart attack in a patient, how can I assess to see if someone actually had it or not? So that's why it's really important, especially in family medicine, where the specialty is so large, and every single patient you see is completely different. It's not like a cardiologist, where predominantly the most of the patients they see is cardiac related. I mean, as family medicine, you can see a 3-day-old, then an 80-year-old, then a 15-year-old, and then a 40-year-old, and it's GI complaints, then musculoskeletal complaints, then heart complaints. So you really have to be on your toes and being aware of differential diagnosis for anything. Any other questions so far? Do I use OMM? No, I don't. Did you take a gap year? No, I did not. I went straight through. I know the audio is not great. Sorry, my Wi-Fi is not fantastic, guys. What did you do to stay on top of your studies in med school? Lists are always really great. Having short-term goals, and just keeping track of what you need to do, and just writing it down and making study plans. Let's see. How's family medicine different than pediatrics? So I'd say the first question I would answer is, how's family medicine different from internal medicine? Yes, internal medicine does do some level of women's health. It's not as extensive as family medicine, but they do not do pediatrics and OB. Pediatrics only does children, so anything under the age of 18. Family medicine does birth to death, so everything. Undergrad major was biology. What is your take on preventative medicine and integrative medicine? I think it's really cool. I mean, I think everything has their role. Some things work and some things don't. In my residency, we actually had an integrative medicine department, and they did some fantastic things. We sent our Bell's palsy patients to them first before we did the traditional medicine treatment. And women who had babies that are turned around in the wrong direction that would traditionally have to go for C-section, we were getting them turning around with acupuncture so we could spare women C-sections. So I think integrative medicine has its role, and it's quite cool to see. What are some clubs we can join during our gap years? I mean, I think it would depend on what your organization offers. How many shadowing hours did you do before med school? To be honest, I don't remember. That was a long time ago, so I don't really remember. I use most of my clinical work for my resume was through my clinical research. Can you pursue the same specialties with DO? Yes, absolutely, 100%. Is there any measures to limit the amount of antibiotics given to patients? Yes, there absolutely is. We talk about something called the art of medicine. You may have heard that term or come across that term before. It's about educating your patients. So if someone comes in, and this is just a big thing in family medicine and any specialty in general. I mean, every patient, every system's going to have their patient population with a certain amount of what was the term I was going to use? Expectations, right? Every patient comes in with an agenda, and you as the provider have an agenda. And this is an important part that I want to talk about, how to talk to patients. So spend a couple minutes on this. You're going to go into medicine with good intentions, right? If someone wants antibiotics and they're not warranted, or someone wants an opiate and it's not warranted, then you know that, right? Because you're a physician, you're trained, you've seen this hundreds, if not thousands of times, and it's not clinically indicated or it's not good for them. You're not doing that. You're not refusing their opiates or their antibiotics or their steroids from a malicious place, right? That's not where this is coming from. That's not where you're coming from. And patients can get mad. They will get mad, and it's about how you communicate. And if you explain to them honestly why you don't want to prescribe them that at XYZ, whatever. And something we always say is, and it's true, it's if you were my mother or you were my family member or you were my sister, my brother, this is not something I would want to give for you. This is not something I would want you to be on. And I think if you really just be open and you honest and you don't just shut them down and say no, people respond very well. So there's absolutely ways to limit if you don't feel comfortable. Let's see. How often do you see mental health issues in family medicine? Multiple times a day, every day. Mental health is a very serious problem that gets very under addressed, and there's a lot of stigma against it, unfortunately, even still to this day. So it does fall on family medicine predominantly, or not predominantly, but a lot, because we are the very first line people out there in the community. So to diagnose it, to recognize it, to address it at some level is something that we do a lot as well. Do you think med school prepped you for a pandemic? No, not a bit. Nothing can prep you for something like this. Where is that quote from? Oh man, you got to look it up. Or no, you can look it up. You just gotta know it, man. Best way to take notes in med school. Oh, it depends on your question or your learning style. Some people go through. It's better for them to sit in lectures. Some people don't and do the recordings. It just depends on the person. What extent do you collaborate with other doctors on diagnosis? All the time. You have people that have been out of training for decades, and you always see them going across to each other's offices and asking their other colleagues, "Hey, can you come in and take a look at this rash? I don't really know what this is," or "How would you address this?" Or "Patients coming in with this, this, and this. Do you think this is the right thing to do?" That's what your consultants, that's what your specialists are there for. If you don't know or you're not sure about how to prescribe a medication, one, you can always refer, and two, you can always call someone up and say, "Hey, I have this patient. This is what they're coming in for. This is what some of their labs and imaging said, but I just don't feel comfortable. I'm not sure if this is the right thing to do. What would you suggest?" So all the time. I mean, I think it's a common misconception that physicians don't ask for help. No, people are asking for help all the time, no matter how long you are out of your training. So yeah, all the time. Yeah, how do you talk to patients that don't seem willing to follow your recommendations, recommendations in of taking medications and lifestyle. It's hard. It can get a little frustrating, right? I mean, you have an uncontrolled diabetic and you sit with them for God knows how long, and you refer them to a nutritionist to talk about their diet, and you really got to cut out sugar, and then they just don't do it, and their diabetes is out of control, and then they have a heart attack. It's complicated, and it's hard, and it can get very frustrating. But patience, you just be patient with them. You have to see where they're coming from. You have to find out what's going on in their life. It's easy to call someone out on having a bad diet, but if they're a guy comes in with diabetes and he's the sole income provider for him, his wife, and his 4 kids. And, he doesn't have time to make breakfast in the morning because he's up at 4 a.m. and then works 2 jobs and, has a low income. So he can only, afford cheap food or go out for McDonald's for breakfast and, doesn't have the time or the money for it. You wouldn't know that unless you ask them about your life, tell me about your work day. What is your job? How many kids do you have? I mean, that's all part of the social history that you take that is important. So yeah, it's tough. So you have to have some level of understanding about what's going on in people's lives, and every patient is different. So it's not that just by treating diabetes or high blood pressure that you are doing the same thing every single time. It's not. Every single patient is different, and that's why it's so fun. What do you think about the high school GPA MCAT stigma for med school? Honestly, by the time you're applying to med school, no one cares where you went to high school. That doesn't really mean too much. MCAT, I don't want to comment too much on MCAT. It's actually changed twice. It's been totally revamped twice since I took it. So honestly, that's so far out of my knowledge base at this point. Probably not the best person to ask for that. How do you determine what a patient has during the visit? What's your strategy? So that's what we'll talk about in some of these couple cases. So let's go ahead with the first case. Oh, a master is someone who has failed more times than the apprentice has tried. I mean, that's really all it is. And that's one of the quotes I'll talk about later it's just about volume. The more you see and the more you do, and the more you push to get as much patient care in as possible, the better you'll be. And it's just repetition, like it is with anything, with memorization for some of the classes you're in, right? The more you go through those flashcards, the better you'll remember it, and the better it'll serve you. And this is the same thing with medicine in your training. The more you do it, the better you'll get. All right, time for some cases. So first one, chest pain in the clinic. So keep in mind the scenario. Clinic, for those of you who don't know, imagine you go to talk to your doctor because you want to have your annual physical, and you're just in the kind of clinic, and you're not admitted to the hospital. That's what the clinic is. So 50-year-old white male with past medical history of hypertension, diabetes, and obesity presents for chest pain. So I see that as a chief complaint when I walk into when I look at my computer screen before I walk through. And again, at my level, I have a list of countless 20, 30 differential diagnoses just based off of that before I even walk into the room. But for learning purposes, we'll discuss that a little later in the visit. So if all of you here were med students or you were residents, I would ask you, what are your differentials on the spot there before you even walked into the room? But we're going to talk about that a little bit later. So how am I talking to the patient here? So what's coming up in this next paragraph, they're saying this makes it worse or this makes it better, or they don't have this symptom. These are all questions I'm asking. I am asking these questions based off my list of differential diagnoses. So he describes it as the center of his chest. It's 2 out of 10 pain, described as a burning sensation that has lasted for the past 2 days. He has not taken anything for it. He feels that eating makes it worse. He does have a cough and heartburn symptoms. He denies fever, productive cough, congestion, shortness of breath, vomiting, abdominal pain, radiation. Radiation meaning pain, meaning it doesn't travel anywhere else. So let's break that down real quick. Location, where's your pain located? How bad is it? How would you describe it? How long has it been going on for? Have you tried anything to help your pain or your symptoms? What makes it better? What makes it worse? Any other symptoms? So fever, when I ask for fever, I think it's only, let me skip ahead for a second. We'll come back to that. A little bit more vital signs. So vital signs tell a lot. It's called vital signs for a reason, because this information is vital. It's critical to your assessment of the patient. So blood pressure is normal. Heart rate is normal. His oxygen levels is normal. He's overweight for his height. General exam, NAD, no acute distress. He's fine. Look at this picture. This guy's smiling. He's fine. He looks happy. Normal cephalic, atraumatic, eyes are intact, nasopharynx is clear, chest is non-tender to palpation, palpation meaning feeling, touching, heart is fine, heart sounds perfect, lungs are clear, abdomen exam, it's not tender, I don't feel any masses, he's not guarding, meaning he's not having difficulty with the exam. Again, this guy looks fine, as opposed to the next case, which we'll see in a second. You know, in the clinic setting, with him looking so well, how I approach a patient in this scenario is I think of the common diagnoses first. Of course, I consider everything, and this will make more sense when I talk about the next case of why I said thinking about the most common things first. So differential GERD, acid reflux, allergies, costochondritis, pneumonia. Of course, I'm thinking about heart attack. I'm thinking of blood clot in the lungs, etc. But again, my first and primary thing based off his presentation and what my exam was acid reflux, allergies, costochondritis, things like that. So let me go back a couple of slides. So looking at the last three sentences, eating makes it worse. He does have a cough and heartburn. That is symptoms. Again, once you go through the med school and you're learning about pathophysiology, those are things that are fairly suggestive of acid reflux. Denies fever. Well, he has chest pain and has a fever. I'm a little bit more worried for an infection like pneumonia. As same thing with productive cough, congestion, shortness of breath. Is he having a pneumothorax or a collapsed lung? Is he having a blood clot in the lung? So without that, a little bit less suspicious for that. Is having difficulty walking, meaning like, is there an obstruction in one of the arteries for his heart? And so he's having something like the heart attack. He's not having what we call angina or chest pain or difficulty or pain on exertion. He's not having that. So again, suspicion goes a little bit down. Vomiting, abdominal pain, right? You can have a perforation of your intestines and then gas because, right, what does gas do? It rises. It'll go up to the top of your, or the bottom of your diaphragm at the top of the abdominal cavity, and it feels like chest pain, but he's not having any abdominal pain. So probably not. So, my differential diagnosis, I have to think of these different things like pneumothorax, like perforated bowel, like all these things. And I have to ask questions that are suggestive of that to rule out, that's the term he'll rule out different diagnoses. So that's kind of what that is. At this point, how do you investigate and what do you do for the patient? So patient comes in, you see their vitals, you see their presentation, you ask them their history, you get the history, you do your physical exam. There's two aspects to what happens. It's what do you do to further diagnose the patient? What do you do to the patient? And what do you do for the patient? So yeah, some level of this is going to be, what do I need to do? Is there any imaging I need to get? CT, X-ray, MRI, whatever. And what kind of labs might I need to get to investigate a potential diagnosis for the patient? How am I going to treat? What medications am I going to do to alleviate the symptoms? Medicine is customer service to some level, and someone's coming in with complaints. You need to treat their complaints. How would I call it? I call it GERD. And based off of symptoms, I probably wouldn't do any further investigation at that point. We're not getting into all of what I would talk about, but I would say, hey, what's your diet like? What are you eating? What are your symptoms? What time do your symptoms happen? If he says, yeah, I eat a lot of fried food and my symptoms tend to happen more at night when I lie down. I have to sleep in a recliner because it props me up so I don't have as many symptoms. Seems suggestive of acid reflux. So I would treat with a PPI or an acid inhibitor for 8 weeks for a trial on that medication. I would talk about, hey, this is what you should do to have a better lifestyle. I would recommend exercising to lose weight. That can contribute to acid reflux. We talk about diet and what healthy alternatives. We talk meal prepping once a week. So the guy who works, 15 hours a day, who doesn't have time to cook, only has to do it once a week and can have at least some of his meals at home that are a little healthier and not necessarily inducing his symptoms. And we talk about what are the danger signs, because I could be wrong. It may not be acid reflux. So we talk about what are the things that you should be looking out for that I would say, hey, I might be following up with you in 8 weeks to schedule a follow up with you, assuming it is good and see if my treatment worked. But just in case something happens and you're getting these other symptoms in the meantime, and you don't know if those are bad or red flags or not, I want to talk to you about that so you can come in and get evaluated or go to the ER or call me to see if you need to be assessed sooner than that. So that's kind of how we talk about it. And again, it's not simple. Again, when we diagnosing acid reflux can get very complicated. You have general surgeons who specialize in GERD surgery. Yes, you have partnerships between primary care physicians, GI doctors who will do and all these kind of pH testing with different probes, those and all this testing. Then you have to consult with a general surgeon as well. So acid reflux may sound very simple, but it can get extremely complicated. So does the patient even have insurance? Can they afford a X number of weeks hiatus because of potential surgery from work? Can they afford the workup? Again, do they have the resources to have the lifestyle? Do they live in an area or have the time to go exercise? And it does get complicated. So again, nothing is simple, but that's kind of a basis of how to assess a patient in the clinic. Let's see about questions. What keeps you motivated after a difficult long work day? You got to have hobbies. Find something that you enjoy doing, whether it be exercise and meeting, be from the pandemic. Still going to put that out there. Being with your family during work itself. You have your colleagues. You go out to lunch with your colleagues. You have a great patient encounter where patients are so happy that you were able to treat them, and you just have a good experience. So there's different things throughout the day that definitely help someone going. You mentioned stress as a factor. How do you draw the line because physical and non-physical causes to pain and illness? That's tough. I mentioned stress as a factor with chest pain. You have something called Takotsubo syndrome, or it's called the broken heart syndrome, where people will get admitted to the hospital because it looks like they're in heart failure, they're having a heart attack, and you do all these things with cardiologists and all these interventions, and suddenly they're perfectly fine. Their vessels are completely not blocked at all. There's no evidence of a heart attack, but it looked like that on the lab results, on the imaging in the ER of the clinic. So, and that's caused by stress. So it can have some very serious complications. As far as physical and non-physical causes to pain, illness, it's hard to explain. I think it just comes with experience and seeing hundreds of patients, and especially in family medicine, when you have your patient panel of 2,000-3,000 patients, and you see them over and over and over again. You just get to know them. You just know someone, and you can tell. And you have to be aware of site causes and what their other comorbidities are, and what kind of work do they do that may be inducing physical strain on their chest cavity and things like that. So it's about asking questions and just having a little bit more experience. Let's see. My GPA and MCAT. Mine, I took the MCAT. It was 3 sections out of 45, and I think I got I don't remember. I think it was in the high 20s. It wasn't fantastic, to be honest. My GPA was 3.3, so again, not stellar. But my extracurriculars and my personal statement were awesome. So I think that's what did it. I'm lucky. Thanks for doing this. You're welcome. How do you deal with patients who become agitated with you during their appointments? Yeah, you just can't get mad. You can't get mad. You have to learn how to shut it down, essentially, while being safe. There's always help. There's always security. I've honestly lost count the amount of times I've been in the ER during med school or during rotations, and for a number of reasons, patients angry or patients having a psych issue, and people get assaulted by patients. I'm sure people hear about it in the news, but it happens all the time. It happens. Does this ever bother you? Nah, it gets to you sometimes when people call you out and yell at you. It's disheartening, but it's okay. You move past it. I heard that residencies are harder to get into as a DO. There are some specialties. I mean, ophthalmology, dermatology, those are competitive specialties, and there's not many residencies. They tend to be at your name places like Ivy League schools, etc. There's unfortunately a stigma about DO. So there are some programs in a number of specialties that they won't say they won't take a DO, but you look at all their residents on their website for years and years and years going back, and they don't have any DOs. I think that's pretty telling. So yeah, it can be hard in some aspects. What is your opinion on the U.S. healthcare system and the daily issues with insurance? I'm not going to comment on that. healthcare issues because that gets too political. I don't want to go there. But any daily issues with insurance, I think it depends on the system you work in. If you work in a county hospital where predominantly your patients don't have insurance, it can be an issue as far as finding resources. For example, someone had a stroke and they were in the hospital and they still have neurologic deficits, and you need to organize home health for them because they can't get in and out of the bathroom or their bathtub or take a shower, or they can't eat because they have a facial droop and a speech deficit. How do you organize help for them afterwards? I mean, yeah, diagnosing a stroke in the ER or treating a stroke and working that up in the hospital is all fun and exciting, but that's the easy part. The social aspect of this and teaching them how to eat and determine if they even can eat and organizing that's the real medicine. As a med student, you won't deal with a lot of that because that's what the residents and the attendings are doing. So there's so much more to medicine than just treating the actual disease process itself. And I think that's the fun part as well. So insurance issues can be a thing about getting patients help. How do you talk to patients from a different culture? It can be hard, and I'm glad you asked that question because it's very important that people are aware of people's backgrounds. For example, if you have a Hispanic patient that has, I talk about diabetes a lot just because it's so common, Hispanic patient with diabetes, and their diet predominantly consists of a lot of corn tortillas, some food with very high glycemic index, and you know, refried beans and rice. I mean, it's not reasonable to tell someone to abandon their ethnic foods, and that's just not going to happen. They're going to tell you, no, forget you. I don't want to do that. So being aware of cultural values and cultural systems is important because if you alienate a patient, you've lost them. You lost them, and then what? Something bad happens because you couldn't connect with a patient. So it's a thing. You have to be aware of people's backgrounds and their cultures, and that plays a part. Absolutely. Do you recommend jobs for pre-meds to have during college? It depends on you. That's a very individual, personalized decision that you have to make. Does being a CNA during undergrad help with patient care hours? I think so. I know going for something like PA school, they require you to have a certain amount of paid hours of patient care work. You don't have to for med school, but I would imagine that that's good experience. Yeah. Do you have a required number of patients you need to see per day as an attending? Yeah, there is a schedule, and you have to meet that quota, and there's access needs, and sometimes you have to take more during residency. You have depends on your program, your residency program. Many places have patient caps, so to protect you, you have a certain amount of patients that you can see. They don't want you going beyond that. That doesn't always happen in reality, but on paper, yeah, there are some limits to that for your training. How do you see technology transforming your field of medicine? It's especially relevant right now with COVID. Telemedicine, video visits, telephone visits, etc., has always been around the last decade or so, but it's fast becoming more important. It's going to be something that's going to be far more involved now than it was 8 months ago. For the future of every specialty as well. How have we been able to adapt to the changes in the medical field? Technology changes. It's you just do what you're told. You come up with solutions. Leadership comes up with options, and you just adapt. And I don't know. I find telemedicine a lot faster and a lot quicker. To be honest, I think it's pretty good. Thoughts on step one being fast fail? Yeah, it's when you're going through that stage, it sounds great to have a pass fail system because it's so much less pressure. So much of, especially these competitive specialties, what they base your application on, if they're going to take you, is your step one score. So for an applicant, it's awesome. Absolutely. It does make it a little bit harder, and I did some stuff with interviews and filtering out applications for my residency. It makes it a little bit harder on that end because it's how do you filter out people when you get thousands and thousands of applications and you can only interview 100 people, some level of filtering system. So it does make it hard on the back end of it, but I think it's great. Did you work during med school? No, I did not. How'd you manage the course though? Looking back, it doesn't look as bad as it was during the time. Some days were better than others. Some times are better than others. it's always going to be hard, but if you love what you're doing and you're surrounded by good friends and you're all suffering together, misery loves company, it's fun. It is fun. And if you're having fun and you're enjoying it, then the work is manageable. And however hard it is or however stressed that you're getting, it's okay because you're enjoying it so much. Um, okay, let's go on to the next one. Let me try and scroll up. Sorry, I know I'm trying to answer as many of these as I can and still be on time. WebShadowers, let me know if I am off or how I'm doing with time. Chest pain in the ER. So I don't do ER, but I've done a lot of ER through my through my training, and I do a lot of urgent care work. So I feel very comfortable with a number of ER scenarios and things like that. So let's talk about chest pain in the ER. Similar situation, diabetes, or 50-year-old white male with past medical history of diabetes, hypertension, and obesity with chest pain. Index of suspicion is higher. Why? Yeah, people do abuse the system, but generally, if someone's having chest pain bad enough that they think they need to come into the ER for it, as opposed to waiting, a few days to get into my clinic, I'm a little more suspicious at that point. Again, at this point, my differential diagnosis is forming for me here. So again, how am I talking to the patient? Yeah, I'm still going to try and be as empathetic as possible and get the big picture, but I'm going to be a little bit more direct. So I'm asking a lot of the same questions, keeping in mind my differential. So he described it as the center of his chest, 8 out of 10 pain this time. Described it as presently for the last 2 hours. He has not taken anything for it. Nothing makes it better. He does have radiation to his left arm, and he's having some associated shortness of breath. Again, denies fever, cough, congestion, shortness of breath. I said short breath, sorry. Difficulty walking, vomiting, abdominal pain. Vitals, blood pressure's a little bit up, 165 over 90. Heart rate's a little bit up, not quite tachycardic, but up there. O2 sat's fine. Again, obese patient like we saw. This is what this guy looks like. Okay, very different from the other guy from his picture. This guy looks like he's having trouble. Head exam, eye exam, neck exam is clear. Chest is non-tender. Heart sounds fine. Lungs sound fine. Abdomen sounds fine. So physical exam is fine. But again, the patient looks not well. That's pretty obvious. This guy looks sick. So, and not so much in urgent care, but similar to an urgent care, and especially the ER, there's someone told me once, there's only 3 things that can happen in an ER. You get admitted to the hospital, you go home, or you die. That's it. It's only 3 things that can happen. So your job as an ER physician is not to treat the whole patient, right? We all have our roles to play. Primary care physicians in the clinic are the frontline providers, and they deal with a lot of the stuff. ER providers deal with trauma. They stabilize the patients. They deal with these very acute situations, and then they admit the patient. And then the hospitalists, whatever specialty they're from, family medicine, internal medicine, they are treating the patient long term, and then they discharge the patient. And then your PT, OT, family medicine people, primary care people follow up afterwards. So we all have our roles to play in the course of a patient's care. So in the in the ER, your job is to diagnose the patient and stabilize the patient, and we call it dispo. What's their disposition? So again, the 3 dispositions that can happen in the ER are you get admitted to the hospital because you're sick and you need workup or you need treatment, or you go home because I think you're okay and you're going to follow up with your primary care provider, or you die. So this patient looks sick. He has some suspicious comorbidities that put him at risk for things like heart attack. My first impression is he's getting admitted to the hospital. An ER doctor can tell that like that. There's not many people that can beat the gut instinct of an ER doc. So if an ER doc walked into the room and within the first 5 seconds can tell, hey, this patient's well or this patient's sick, and I'm probably going to admit this patient. I don't know what's going on yet, but this patient probably needs to come into the hospital. So my job here in the ER is to think of what can kill this guy in the first few minutes. So that's how I think about this. My differential diagnosis for this situation would be STEMI, or ST segment elevation, MI, or NSTEMI. You don't worry about the terms right now. Basically, heart attack, pulmonary embolism, PE, tension pneumothorax, aortic dissection. Those are my level first 5 because again, those are the diagnoses that could potentially kill the patient in the next few minutes. That's something that needs to be treated now. That may need to go to the OR now, etc. Second tier of diagnoses. They could have ACS, which is I won't get into it, similar to an MI, basically a heart problem, pneumonia, sepsis, appendicitis, pancreatitis, ulcer, things like that, that may or may not kill the patient right now in the ER, but they need to be treated and they need to be admitted to the hospital. So that warrants further workup. GERD, costochondritis, kind of like we saw in the clinic patient. That's not going to kill the patient. Yeah, it sucks. They're going to be hurting and uncomfortable, but that's not going to kill the patient. So you have to think about it in 3 levels. And I think it's on the next slide. Yeah, in the ER, I've been told this so many times by ER physicians. In the ER, any aspect of medicine, it's almost like guilty until proven innocent. In this situation, I have to assume there's something bad or fatal going on, potentially that's going to kill you. I have to assume it's something like that, and I have to prove that it's not before I can let you go home. And this comes into what I said before about, what are you doing to the patient to investigate, and what are you doing for the patient? So what would we do for this guy? I'm going to assume at this point that it's one or multiple bad things and start treating and investigating at the same time. So pretty standard workup for someone with risk factors coming in with chest pain. You do troponin, that's a heart enzyme you look for, chest x-ray, EKG, other labs, etc. Put them on the monitor, look at their heart rhythm, look at their oxygen levels, monitor that as you're sitting there throughout the ER course. That's my investigation. I'm going to give them potentially nitro based off their EKG findings. There are some contraindications to nitro in chest pain, but nitro, I'm going to put them on the oxygen monitor. I'm going to give them an aspirin. Again, I'm not trying to make this a lecture about medical trials and things like that. That's not the point of this. But aspirin is one of those critical meds that heart attack patients you need. I mean, people lose their license if you're not doing that. So that's a thing. And once this patient is stabilized, I'm admitting them to the hospital. That's it. If I find a diagnosis, such as, that's it, it's a heart attack, I figured it out, I'm done. I'm done as an ER doctor. I am done. That is the limit to where I need to do as far as treating this patient during the course of their disease process. I'm admitting to the hospital, and the hospitalist is taking it from there. And I'm moving on to the next patient or patients because I have 20 more in my waiting room. So that's how you would kind of approach it in the ER. It's slightly different acuity, different level of involvement into the patient. It's not that I don't care, but in this situation as an ER tech, I'm not worried about what their lifestyle is. I'm not worried about what they do for a job or how many family members they have. That's not my role as an ER physician in this acute scenario. So you're being empathetic in different ways, and even if it ends up being just acid reflux, it was bad. It was bad enough that this person felt the need to come into the ER. I mean, people don't walk into the ER because they want to have a good time. Yes, some people do, but generally they don't. I mean, this guy's having a bad day. So be empathetic, and yeah, you could do this whole workup, and it's very easy to fall into the trap of, man, this was like such a waste of my time. It wasn't even anything. And you get frustrated, and that's a bad mentality to have. It doesn't do you any well. It doesn't do any patients any well, and it's hard to hide that if that's how frustrated you're feeling about it. So you have to be empathetic to these patients. Some people do come in with chest pain and they say it's a 10 out of 10 chest pain, and they're sitting there smiling at you and laughing, and on your cell phone, we call it the positive cell phone sign. You're probably not having a heart attack. You're probably fine. You're probably not in 10 out of 10 pain. Let's go some more questions about that case scenario. Let's see. What's the most difficult part about medical? I'd say the first 2 years. That was tough. Sitting and studying like 10 some plus hours a day. It's tough. How do you accommodate patients without insurance? To me, my philosophy is that's not my job to worry about that. That's administration stuff. So I'm going to treat the patient regardless. Let's see. Yeah, shadowing in person is probably not going to happen for people right now. Virtual shadowing like this, which is great, is probably the way to go. I've heard of doctors that they just prescribe the medication and that's it, instead of going over other factors due to this. Is this the way of working, or because the institution they work for? It can be because of people's training, and that's how they were trained. It's hard in the clinic setting, right? A patient shows up 10 minutes late, and it takes 10 minutes to room them to get their vitals and have the nurse get them ready to go, and suddenly your next patient's already here and now you're behind. And there is a lot of pressure. There's a lot of pressure on the physician to be on time. And so sometimes you can't spend the time you want because I'm still a human being, right? I don't want to sit here till 10 p.m. and seeing patients in the clinic when I'm supposed to be done at 5. I want to get home. I want to see my family too. So there is some level of priority for me to, get done with my patients on time and get them out of there and finish my notes and finish my work. That's not an excuse to shortchange the patient experience and not explain to them what's going on. So it happens. Some institutions like the one I work for are very cognizant of that, and you're not, see 10 to 12 patients in a half day, meaning a morning session, versus I have some friends who practice in places who are seeing 18 patients in the morning, and that's an obscene amount of patients. I mean, that's crazy. So yeah, if you're having to do that and you want to finish on time and actually have a lunch and get your staff on time out to have a lunch, you probably won't have time to sit and explain everything and go over everything. And that's not the best scenario, but that maybe is institution driven a little bit. And it may just be from their practice style. So that's a complicated question. And, we try our best. I'm sure most people try their best. Absolutely. Not sure if this was mentioned. How many hours per week do you work? 40 right now. And do you think you've done well with time management or work-life balance? Yeah, I think I did a good job. I have a lot of family who are physicians, so I had a lot of help and guidance on that as well. Are you allowed to suggest alternative medicine to a patient? I don't prescribe it. I do have a little bit of knowledge on it. So I tell people, look, I can imagine if they say, hey, what do you think of this supplement? I could say, look, I don't know much about it. From what I do know, it probably wouldn't harm you to do this, but I can't give any recommendation on it. And I think that's the big thing. You do get some level of training, especially in family medicine, about alternative medicine, supplements, things like that. And like it or not, they're out there. So whether or not they work or not is not exactly the point. I think you have to have a little bit of knowledge to say, hey, this is probably not going to harm you. And if you choose to take something, that's up to you. I can't give a recommendation on that. So, um, to advise for any people with social anxiety for med school interviews in the clinic, et cetera. Yeah, I mean, stage fright, anxiety, talking to patients is hard. It can be very scary and very daunting and intimidating practice, and that's what you'll do during med school. You'll have OSCEs or standardized patient encounters that you'll do to practice. You'll practice with your friends. You'll practice throughout your rotations. Practice. If there is true underlying anxiety, you'll talk to your doctor. Let's see. Volunteering abroad, I guess. Yeah, why not? Let's see. If you were stuck on a diagnosis, how do you proceed to figure out what is wrong with the patient? Good question. And I think, first of all, again, like I mentioned before, you have to have a differential diagnosis in place, and you have to investigate based off what your differential diagnosis in. Again, like I said again as well before, you always have help. You can always consult someone or ask someone, a specialist or a colleague. Sometimes you're going to miss stuff, and that's okay. It happens. Charting. I have a few more. Let me hurry because I'm at 6:53 already. HPI, family history, social history, surgical history, allergies, review of systems, physical vitals, assessment and plan. These are all things that you have to do in training. It's not just talking to the patient, giving you recommendations. You have to chart all that stuff too. That's part of your workflow. So that does take time. So you have to make sure you do that as well. That is part of the workflow, like it or not. Other considerations about primary care in general, and this is all part of it. I mean, it's not just medicine. Being a physician is so much more than that. It's how quickly did my staff get them in and start the visit? Do I see this patient first or another? How acute is this patient? Do I skip the first patient because they're probably not as serious as the next patient and come back to them? Did I chart this correctly? Did I build this correctly? Meaning, me or my staff going to get paid for this because I didn't build this correctly? How quickly can I get this done to make sure I get to the next patient on time? How was the patient experience? If they had a really bad experience, they're going to write a formal complaint against me. They might. Did I explain them properly? Do they feel comfortable? Do I need to call or refer or consult? I mean, there's all these things that come in for every single patient scenario. So it's a lot to think about for sure, especially in primary care. When are they going to follow up? Are they going to follow up? Who are they following up with? What help do they need? How are they going to get their medications? How are they going to manage at home? Again, every single patient that this comes, and it's not like I'm just doing heart patient, heart patient, heart patient, lung patient, lung patient, lung patient, thyroid patient, thyroid patient, thyroid patient. It's not. I mean, family medicine is so expansive, and it's literally every specialty all at once. So um, you always have to think about this stuff as you go along, and that's what's great about family medicine training is you are taught how to think about all of this at once, and every 20 minutes you're thinking about this all over again. And it's cool. Summary, highlights, learning points. You have to think about things, as I said in these two cases, think about things a little differently depending on what situation you're in. You have to see hundreds of patients to get good at this. And you have to learn empathy, compassion. No one likes a rude doctor, right? That's not a good patient experience. And again, your job is to treat the patient. Your job is to manage their chronic conditions for over decades. It's not like you're a hospitalist and you can have the luxury of treating the patient for their 1 to 3 days or however many days they're in the hospital, and then you're done. They're out of there. As a primary care physician, you're dealing with this marathon that is diabetes for potentially decades. Things get better, things get worse, life happens. So things change and you're dealing with this. So, you have to learn some empathy and compassion and patience in dealing with these problems as a family medicine physician. Treat the patients, not the numbers. That's something you'll hear at some point a lot. That's a very common phrase that we hear. Someone is in the hospital and their sodium's a little low or a little high, but they look fine. Well, at some level, you have to say, well, the patient looks okay, and the numbers aren't necessarily correlating with what I'm seeing on the patient. Um, as far as how they're presenting, you treat the patient, not the numbers. I think that's the end. Let me go through some more questions. We have a few minutes still. Did you work during med school? No. Does work experience help during college help in admissions? It might. Depends on the school and what they value and who's reading your application. Is it controversial whether farm tech is clinical experience? I don't think so. I think that's clinical experience. You're dealing with patients, absolutely. What is the best and worst parts about family medicine? The best part, it's hard right now. I'm fairly new to the job where I'm working, and building a patient panel is pretty hard. In residency, when I had my panel and I was seeing patients that I knew and I'd known for a couple of years, that's just fun. You just sit and have conversations with them. And when I know a patient that well, I pretty much know before I walk in the room what exactly is going on in the patient. So it ends up being more conversation, and it's great because in residency I had a patient, I had their parents, I had their kids, I helped deliver one of their babies, and you get the whole family and they all start following you, and it's so cool. And they live in the same city as you, and you'll say them at the grocery store and they'll say hi to you, and that can be a little awkward sometimes, but it's great. I love that aspect of family medicine just because I love talking to people. That's the fun part. Most people don't go into medicine because they hate talking to people. You get to do that a lot, and that's fun. I really enjoy that. The worst part is there's a lot to do. It's scary. It's scary walking in clinic, right? You have an 80-year-old patient that walks in on 50 meds, and 50 is a lot, let's say 25 meds, and they walk and they're saying, I just don't feel good, doc. And it's just like, oh shit. Like, are they fine or are they dying right now? And I have 15 minutes to figure it out. And I don't have any labs or imaging or anything in the clinic. I have all my knowledge and my clinical suspicion and my exam and my history. So you have to really be on your toes. So I think it's one of the worst parts about family medicine is it is so broad. And it's scary. It's scary sometimes. You want to miss something. Bad things can happen, absolutely. Let's see. How has COVID affected your daily work? Not really, to be honest. Not that much. During telecare, how is it compared with an in-person session with patients? It's hard. It absolutely is hard. Like a video visit, at least I can see a patient and see if a patient looks super sick or super ill. On a telephone visit, it's hard. I mean, if I have a telephone appointment and someone's having abdominal pain, how am I supposed to examine that? I can't examine someone's abdomen and put my hands on them and feel that there's something wrong. So it's hard. It's very hard. Sometimes you just have to tell them, hey, I can't do this. You have to come into the clinic. What research did I do? Ultrasound. So I dealt with bedside for procedure ICU and in the ER, and it was really cool. That was about 10 years ago, coming up on it, and I've been doing it a lot since then. Been to ultrasound conferences, had a couple publications, etc. So that's something that I really enjoy doing that I've kept up to this day, which is really cool. What did you find most challenging about rotations? Probably waking up at 3 a.m. for my surgery rotation. That was tough. The 36-hour calls, that was tough. 24-hour shifts every 3 days. Those were tough, but you get used to it when you're doing it with people that you enjoy, hopefully. It's fun. It's okay. You get through it. Why is panic attack not one of the differentials? It's definitely in there. I couldn't list out everything, but it's definitely one of them. Absolutely. But you do Jennifer was saying, you don't have to necessarily have a psych history or a diagnosed psych history to have anxiety or a panic disorder. Hospitals do have translation services, which is very helpful, of course. Yeah, if they can't speak, sometimes they can write. Yeah, we do that. We do that for patients who are paraplegic or whatever, or can't speak or anything like that. It's a good approach to finding DO doctors to shadow. Looking at your local hospital, maybe an affiliated hospital with your school, and just emailing. Just email, ask. What do you think help you stood out in your application cycle? My research definitely did. My extracurriculars and my personal statement, I think, helped me stand out the most. What was the diagnosis of the psych case? I don't think I actually put that. I think I just assumed it was a heart attack. But again, as I said, my role as an ER doc isn't necessarily to 100% all the time find a diagnosis. It's finding something. I'm finding a reason to send a patient home. I'm finding a reason to admit a patient to the hospital. So that one, I was hinting at that he was having. That was the diagnosis one. GERD for the first one. Yeah. We did too. Chest pain in the clinic and chest pain in the ER. Let's see. Is the MCAT required this year? I'm pretty sure MCAT's going to be required regardless. How do you keep yourself motivated through the long process of becoming a physician? One day at a time, one rotation at a time, 1 month at a time, and find stuff besides work to keep you going. Again, sports, hanging out with friends, etc. Are there opportunities to work abroad as a DO? Yeah, you can do like medical missions and stuff like that. Absolutely. How helpful are scribes to you? I don't know. I feel like scribes are not happening as much. I know there are some specialties like ER that are doing it a lot more. I feel like I'm usually quick enough, and I know my electronic medical record fast enough that I don't really use one or feel like I need one. But I know a lot of people do find them helpful sometimes. Do you recommend students becoming scribes? It's definitely an option. It gets you clinical experience, get them, involved and whatnot. So yeah, absolutely. It's something you can do. Do you utilize OMM in your practice? No, mostly because I'm not really interested in it, to be honest. And number two, it takes time. OMM takes time to do. Diagnosis and treatment can take half an hour to do on patients, and I only have 15 minutes per patient, so it's just not feasible in traditional practice, regardless of what specialty you're in. Challenging case so far. Ooh. I mean, I can go into some random crazy things that we've seen. I think the ones that I think now that I'm a little further in, like out of training and whatnot, I think challenging ones is when things go bad, and let's say you miss something, or delay in care, and it's like, in the end of the day, that was my fault, right? It's not my nurse's fault. It's not my front desk's fault, and the line ends with me. So if you miss something because you didn't think of it or something like that, that's hard. And it'll happen. It's going to happen throughout your training and throughout your career. I mean, we're only human. You do your best, and I'd say in general, those are the challenging cases. It's when you just don't know. Sometimes you just don't know, and it's okay to tell people that. I think most patients like hearing that. You can tell them, look, I actually use this phrase quite a lot. I say, look, I don't know that I know what's wrong with you. I'm pretty sure based off your symptoms, or I feel pretty confident that there's nothing dangerous going on, but I don't know. But based off what I think may be causing it, we can try X, Y, and Z interventions or treatments to see if it helps. So it's okay to say you don't know, and I think patients really like that. They appreciate that. And if you think it may be related to an endocrine problem and you just don't know, you can ask endocrinology or refer them. Again, that's okay. Financial tip for med school. I took loans through. When you become a resident, your salary is not that high. Live frugally. See if you can pay off some of the interest as that's accruing during your residency or during med school. See if family can help you. You're going to have debt unless you're lucky enough to have people who can pay that off for you. Your salary goes up quite a bit when you become an attending, so we'll pay it back. Don't go buy $1 million house once you finish residency. Don't buy a super expensive car. Live frugally for a few years and use that high income to pay off your loans. Everyone does it. Not a huge problem. All right, it's 7:05. My hosts, should we keep going? Do we have time? Should we end?
Yeah, you can keep going.
You can keep going.
Okay.
We'll go ahead and put the link out now, and if anyone wants to ask further questions, they can stay and ask further questions, if that's okay with you.
Absolutely. I can stay off for a few more minutes. Absolutely. Any advice on building self-confidence as a healthcare provider? I think start doing more and have more responsibilities, and that you start getting things right and you start diagnosing things right. And it's like, I knew it, and I knew I did it, and I knew I got that right, and I was. That builds a lot of confidence. And so I think the more you have that, you get more confident, and that's I think how it goes. Personally, starting as an EMT, I've been stressed out and confused, and was wondering ways to feel more prepared. Yeah, it's stressful. EMT is tough. It's a really tough job. It's just experience. If you feel like there's something, hey, I've seen this scenario a few times, and this goes for EMT, nursing, PA, medicine, whatever. If you see a certain situation multiple times or a couple times and you're like, I just don't have a good handle on it, read up on it. Look it up. We have textbooks. We have ways to start learning more and more about it. So ask people who are more experienced, older people, how do I do this? I'm having trouble with this. Help. You can ask. I think that's the way to do it. Lots of thank yous. You're so welcome, you guys. I'm planning on doing a couple more of these about different cases as well. So we'll definitely have more of this. I think that's more of it. I know I've been listening to the other talks as well, and I know there are some of the presenters who went to a lot of depth about their specialty. But again, and I could talk for forever about family medicine, about the lifestyle. And I wanted to make this as close to a shadowing experience as possible. As I said, you only have 15-20 minutes per patient as a full-time physician, and especially as a pre-med, when you don't have that medical knowledge base yet, because you all will, because you're all going to be doctors and all go to med school, you don't have the time to explain it. So that's essentially how I would explain it to you and how I would explain it to a patient. Listening, in general, you just have to listen, learn to listen to patients, and not interrupt them and not, cut them off. And, you'd be surprised that even sitting, you get a lot of training on how if you just sit and listen for 2 minutes, it's hard. It's hard to sit and let a patient talk for 2 minutes and not want to interrupt something or address one of the concerns that they bring up. But sitting and letting them talk for 2 minutes, 2-3 minutes, and just gathering your thoughts and listening to them and actually looking at them and paying attention and not just sitting on your computer screen doing that 2 minutes can feel like a lifetime, and that makes a huge difference in patient satisfaction and patient anxiety, right? No one comes to the doctor just because they want to, right? They're not feeling well, they're having a problem, and they get scared. I mean, people get scared of coming to the doctors when they're having an issue, and just letting them talk calms them down, and it makes for a better experience for you and them. So learn to be empathetic, learn to talk, learn to listen, learn to alleviate patients' fears. You don't say, "Oh man, I know what you're going through," because you probably don't. I haven't had diabetes, so I can't say I know how you feel. I can understand that this is, just different phrases, and you will get taught throughout med school and residency how to do that. You will. I mean, that's such a big thing in healthcare right now. So you will get taught how to do that. So that'll come. So hopefully you guys will get to do in-person shadowing at some point, and just listen. You can learn a lot by just listening and watching how the doctor types up their note the types of questions that they're asking, the way that they're listening to the patient, the angle at which they are sitting at looking at the patient. It's all important. It really is an art to it. And family medicine is such the prime example, the core example of it. So it's great. Thank you, everyone. Thank you, WebShadowers, for hosting me. I hope to see you guys soon. I have another session scheduled in a month or so, but if there's spots open, I might do more. So we'll see. Thank you for all your questions. I hope I answered that. Let me know on the chat and the comments in the video. If there's anything else, I'll try and answer some more later on if you guys post questions to the video as well.
Thank you so much, Dr. Mittal. We all loved it. It was very informative, and we all learned so much from you. Everyone, make sure you check him out on his socials. His Instagram is Anupam Mittal. Additionally, thank you all for attending, especially on your holiday off, and especially you, Dr. Mittal, because you had the day off. Guys, the link to the Google form has now been posted in the comments, and it's also in our Instagram bio. So please remember to fill it out within the next 30 minutes if you want us to receive your verification of attendance. We hope to see you all in our next session tomorrow. Again, thank you so much, Dr. Mittal. Oh, hello?
Yep, we're good. Thank you, everyone. Appreciate it.
Thank you so much. Thank you.